We worry about bone health and complications long term. If we take the point of view of the patient, then obviously you see a girl here that may have abdominal pain. She worries about her disability. She cannot go to school or go out with friends. Her mood may be low. She can be socially isolated. That is very worrying. And something that is in her mind is surgery, which she definitely doesn't want. And the point of view of the parents is a little bit different also. They think about whether their child can go to school and the impact of the disease on the family, on the rest of the family. And the parents worry more than children about long-term outcome of disease. And then finally, the endpoint of the pharmaceutical company is completely different from point of views from doctors, patients and parents. Pharma worry about pediatric investigation plans, market authorization for their new drugs. They are worrying about the label, and they think a lot about money, of course. So when we assess clinical disease activity in pediatric IBD, it's quite easy. You have multiple apps that you can download on your iPhone that can help you calculate clinical scores for pediatric Crohn's disease or pediatric ulcerative colitis, the PCDI and the PUCAI. That's what we all know. But if we want to score the disease severity, so not disease activity, which is a moment in time, but disease severity, we're talking about disease behavior in time, course of disease over time, therapeutic response, and long-term complications of the disease. And this is a little bit more complicated. So first, looking at clinical treatment endpoints in pediatric Crohn's disease, we all know the Pediatric Crohn's Disease Activity Index, which was developed already 30 years ago now, that comprises history, laboratory markers, and physical examination. And there are also several versions that skip the laboratory markers and skip the height marker, the abbreviated PCDI or the shortened or the weighted PCDI that are a little bit easier to use. Anyway, clinical response is defined as a reduction in PCDI of 12.5 points or more, and clinical remission by PCDI score of less than 10. Easy. So when we assess endoscopic disease activity, it's a little bit less easy. So for this we can use the SES-CD, the simple endoscopic score. It's not so simple because for each segment of the colonoscopy tract, the rectum, sigmoid, left colon, transverse colon, right colon and ileum, we have to score the presence and the size of ulcers, the ratio of ulcerated surface, of affected surface, and the presence of narrowing. And everything added up together can yield us a score. And for endoscopic response, this is defined as a SES-CD of more than 50% reduction. And endoscopic remission, or what we call mucosal healing, is a score less than 3. The problem is that endoscopy does not always reflect the clinical status of our patients. So, for instance, we can have this young girl lying in bed and looking very miserable, but her colon can be absolutely normal. But also the other way around, the happy girl on the lower panel, no complaints, no abdominal pain, but when you do the colonoscopy because of, for instance, some weight loss, you see severely inflamed terminal ileum. So there is not a good correlation between the two. And this is shown in this study by Dan Turner, but also in several other studies, that the correlation between the PCDAI, the clinical index, and the SES-CD, the endoscopic index, is only fair. There's a newer index, the mini index, the mucosal inflammation non-invasive index for pediatric Crohn's disease, that consists of a stool marker, fecal calprotectin levels, and ESR and CRP levels, adding up to a score that correlates better with the endoscopic score than the PCDAI. So for this mini index, the cutoff value of 6, so everything below 6, correlates well with mucosal healing with a positive predictive value of 86%. So one example from a clinical trial in pediatric Crohn's disease is, of course, what you all know, the TISCIT study, a very important study where patients with new onset Crohn's disease, pediatric patients, were randomized to receive first-line infliximab or conventional treatment with exclusive enteral nutrition or prednisolone. And you can see here the results of the first 10 weeks. Clinical remission in 59% of the infliximab, and 34 patients only reached remission when treated with EEN or prednisolone. But more importantly, what I want to show you here is the difference between the mucosal healing, which is in the figure, which was achieved in 17% only of the patients on conventional treatment, and 59% in the patients with first-line infliximab. So there's this big discrepancy between clinical remission, and only half of those patients had mucosal healing. So when we talk about remission in pediatric Crohn's disease, clinical remission is defined by PCDAI less than 10, endoscopic remission or mucosal healing by SES-CD less than 3, and then there's a new definition which we call deep healing, and this is a combination of mucosal healing and transmural healing seen by MR enterography. And if the radiologist scores this as a global assessment on a visual analog score of 0 to 100, a score less than 19.5, then this can be defined as transmural healing. So mucosal healing plus transmural healing, that's deep healing. And now it's interesting to compare this to fecal calprotectin levels. If the fecal calprotectin level is less than 300, this predicts mucosal healing. And if the fecal calprotectin level is less than 100, this predicts deep healing. So let's now switch to ulcerative colitis. Well, we all know the PUCAI, the Pediatric Ulcerative Colitis Activity Index, that was developed by Dan Turner. And it's a wonderful score that we can use on a daily basis. And clinical response is defined as a PUCAI change of 20 or more, clinical remission by PUCAI less than 10. And then going to endoscopy in pediatric UC, but also adult UC, actually is an adult score, the Mayo score that we like to use, that varies from 0, where there is no disease in the colon, to 3, where you see severe ulcerations and spontaneous bleeding. And of course, the mucosal healing is defined as an endoscopy score, Mayo score of 0. And when we look at correlation between clinical index, PUCAI, and endoscopy, this is a little bit better in UC than in CD. Actually, one study states that there's a strong correlation between the two, but 20% of the patients who had a PUCAI less than 10 still had mucosal inflammation. So the correlation is not perfect. And especially in patients with PSC IBD, the correlation is less good. So it's possible that a PSC IBD patient is feeling well but has severe endoscopic disease. So if we focus on the treatment goals for our young patient, her well-being is obviously a goal. But for us as doctors, we want absence of ulceration. We want this beautiful mucosal healing. So for the past 5 years, the treatment strategies have really evolved. The treatment goals have evolved. So first we were aiming for symptoms, clinical remission, and even steroid remission, steroid-free remission, I should say. But what we now want is mucosal healing and even deep remission in order to change the course of disease. So what about the patient? Well, the patient is the one who suffers from the burden of disease. And a very nice tool is the IBD disc that's developed to give patients a self-administered tool to assess disability in IBD. And there are 10 issues that have to be scored by the patient, him or herself, ranging between 0 and 10, such as abdominal pain, regulating defecation, interpersonal relationships, education and work, sleep, energy, emotions, body image, sexual functions, and joint pain. And if you look at this example, this on the left, this is a patient that is initially assessed with active IBD, and the scores are high and the disease burden is high. And what we aim for during treatment is to get this spider web smaller and smaller. So the therapeutic goal is to get lower scores and low burden. In children, there are several studies on self-report or patient-reported outcome in IBD. And all these studies are promising and important because having patients report themselves about their symptoms, this really encourages self-management. And all of the studies show that clinicians really underestimate the disease burden of the patients. So, ladies and gentlemen, I have some conclusions for you. First of all, I've told you that there is a difference between disease activity and disease severity. To assess disease activity by clinical scores, endoscopic scores, or fecal calprotectin, that's easy. But to assess disease severity is much more complicated. Clinical scores do not correlate well with mucosal disease in Crohn's disease. In ulcerative colitis, it's a bit better, but not 100%. And in IBD-PSC, it's worse. There's not such good correlation. Treatment endpoints, it really all depends on the point of view. Is it the doctor's point of view? Then we aim for mucosal healing or deep healing because we know this results in a better course of disease. But if you ask the patients, they want less burden of disease. So, ladies and gentlemen, thank you very much. This is the end. And I'm ready for your questions.
Thank you very much, Henk-Jan. I believe you are online if you want to unmute and show your video. There you are. Nice to see you.
Hi.
So we have some questions in the audience.